And we're gonna get rolling here. I want to welcome everyone to another ALK Talk. We've been doing this for this is our fifth year, actually. We're going to our sixth year. So it's pretty amazing. And we're so fortunate to have Dr. Angel Chin from University of Michigan joining us. And I'd like to say that I'm from West Winfield, Michigan. My name is Mark Rosenzweig. I'm going to be hitting my 12th year soon. And it's very exciting that I'm still around doing this. I'm feeling great. So, and I want to tell you that other ALK Talks can be found on our YouTube channel. And it's ALKpositive.org is our website. And you can also find us there. And you can also find our Healing Arts programs. And I'm going to share something with you really quick and show you our calendar for November coming up. And this is an amazing calendar. Almost every day is filled up with an event. This is a way for you to connect with other ALK patients and get to know each other. We have two new programs. We have an LMD support chat. We also have a multilingual ALK chat on the 11th. So this calendar does change at times. Please go to alkpositive.org under the Healing Arts, Healing Living with ALK. You can go ahead and hit that tab and go to the Healing Arts calendar. So I'm going to also launch a couple polling questions here. Have you had progression, and where was your progression? And the second part is a multi-choice. And this will give Dr. Chin just a little bit of idea of who's in the audience. So we have 54% of us have not progressed, 46% of us have progressed. And the biggest progressions in the brain, 44%, 38% in the lung, 60% in the bone, 19% in the lymph nodes, pleural effusion, 6%, and 6% in the liver, and other spots, 9%. And then we're going to go back to another question here. What is your current treatment?
Also, if there are any burning questions that you have that you think that we should include on our chats, or you have any ideas, you could throw those in the chat. We always love ideas, or you could email us at alktalk@alkpositive.org.
Since you're talking, Summer, go ahead.
But you were doing such a good job, Mark.
My voice is horrible.
Okay, what is your current treatment? We have 3% of you on brigatinib. Add me to that, please. 49% of you on alectinib. Wow, that's awesome. 34% of you on lorlatinib. 10% of you are on chemo with a TKI. 1% of you are on chemo only. 1% of you are on the gilteritinib trial or a gilteritinib trial. 3% of you are on the neladalkib trial. 1% of you are on a different clinical trial, and 1% of you no treatment at all, and none of you are NA. Okay, thanks, Mark.
Okay, I have one more, and that's it. How long have you been diagnosed? Go ahead, Summer.
Let me see here. Okay, 10% of you were diagnosed less than a year ago. Thank you for joining us. Sorry you're here, but so glad that you did find us. 17% of you were diagnosed between 1 to 2 years. 14% of you were diagnosed 2 to 3 years ago. 13% of you 3 to 4 years. 16% of you 4 to 5 years. 14% of you plus me 5 to 6 years. 4% of you 6 to 7 years. 6% of you 7 to 8 years. 1% of you 8 to, did I mess that up? 1% of you 8 to 9 years. I'm like, Mark, why are you shaking your head? And 4% of you are 10 years or more.
The reason I'm shaking my head is my wife's talking to me. So I'm going to stop sharing, and I'm going to go ahead and turn over to Summer.
Actually don't have much to say, if you can even believe it. We were speaking before. Mark was asking Dr. Chin how many times she has been to ALK Talk. We believe this just might be time number 4. And Mark said we're gonna have to get her a jacket like Saturday Night Live for when she comes back for time number 5. So we'll have to come up with something for her. But we love to have you, Dr. Chin, and we so appreciate you spending yet another Sunday evening with us. But first, I am going to hand it over to our very own Dr. Ken Culver to kick us off, give us a little history of Gilteritinib, and what it means to our community. So thank you so much, all of you, for joining us. Mark, did you actually talk about closed captions? I can't remember.
No,
But
but good. Go for it. Also, AI companion. So if you just joined us, you can use that button to get caught up.
yes, but closed captions are on the bottom in case I'm talking too fast, or if you are needing to listen to this in another language, you can go down and select your language and it will be translated for you. So anyway, Ken, please save everybody and take it away.
Thank you, Summer. Thank you, Mark. It's a pleasure to be back with all of you on our ALKtALK. It's a very special part of our whole organization. It's a privilege to be a part of it. Tonight, we're going to tell you about some exciting opportunities that we want to make sure that you know about, and maybe just as importantly, you tell others about. Because while it may not be relevant to today, it could be relevant to others now. And that's a key element of what we're trying to accomplish tonight. So I have 4 slides for Angel and I to sort of kick things off. Here we go. All of a sudden I'm hearing an echo. I'm not sure why. So tonight we're talking about Gilteritinib. Gilteritinib is an already approved drug, also called Aspada.
I think it's Zospada.
Zospada?
Yes.
Thank you, Angel. And this is an oral, it's a TKI. It's approved by the FDA to treat one specific kind of acute myeloid leukemia. It's leukemias that have mutations in FLT3. And because of the mutations in FLT3, the patients are developing acute myeloid leukemia. So among many trials that Gilteritinib has done, and you can see them if you go to clinicaltrials.gov, their phase 3 study that got approval with the FDA, it was called the Admiral trial. And it showed that Gilteritinib significantly improved overall survival compared to the standard therapy chemotherapy, which is exactly how crizotinib got approved in the beginning, is proving that it was better in ALK positive patients than chemotherapy. So it's the same idea. It's given once daily, 120 milligrams. Patients, just like with ALK TKIs, people take it until they progress or if the toxicity isn't acceptable. The toxicities, if we talk about grade 3 or grade 4, in the grading of toxicities, it's 1, 2, 3, 4, and 5. 5 is it causes you to die. 1 is minimal, and then there's a spectrum of 2, 3, and 4 in the middle. The primary ones are, besides bone marrow, because leukemia patients have a really compromised bone marrow, there are a number of bone marrow side effects. That shouldn't be an issue, and Angel will tell us more for ALK patients. The things that aren't related to bone marrow and all the prior chemotherapy leukemia patients get: dyspnea, hypotension, mucositis, muscle aches, joint aches, fatigue, malaise, and elevated LFTs are what we're thinking of besides bone marrow, and Angel can give us a preview. And I saw there was one patient who's on Gilteritinib who's on the call, and if he or she is comfortable sharing their experience, we'd be happy to hear it. So you look at that and you say, well, why then would you give Gilteritinib to an ALK lung cancer patient? And I'd say, that's a great question. And here's the reason. And if my computer would advance, would be good. All right. So it turns out Gilteritinib is what we call a multi-kinase inhibitor. So it's a TKI that doesn't just hit one thing. We know that it also inhibits ALK, so it's an ALK inhibitor. Also, 3 other targets, AXL, LTK, and c-KIT. So it's a multi-kinase inhibitor, unlike lorlatinib and alectinib, for example, which are very, very specific for ALK. So this idea is that it doesn't just hit ALK, but it also targets compound mutations. So I wanted to show you 2 graphs, and these are a lot easier than they look. So the bottom line is the lower you are, the more potent the drug is. So these are all here on the x-axis. These are all mutations in ALK, the ALK gene. And you see here's the famous G1202R. And you can see wherever there's a red star, it shows the relative potency of gilteritinib against these different mutations. And you can say, by and large, in every case, it's more potent than alectinib. And in most cases, it's at least as potent as lorlatinib or more potent on these single mutations. When you look now at double mutations, you can now that you understand that the lower you have in the red stars of gilteritinib, you can see gilteritinib is really potent against a variety of common double mutations. This isn't all the mutations, either single or double, that patients experience, but we wanted you to have a rationale that gilteritinib is not just a FLT3 inhibitor. It inhibits at least 4 other targets, including ALK, and preclinical studies have shown that it's active against both single mutations and against double mutations, and that is the basis for the clinical trials that are ongoing. And so how did we get here? How did gilteritinib even become a possibility for ALK patients? If you were at the summit, you would have seen this slide, but as a reminder, or for those of you that are new, so gilteritinib, there was a paper published by gilteritinib by a group in Japan, Dr. Katayama's group, and it showed that gilteritinib was effective against ALK-TKI resistant cells. And it was posted in our Facebook group. And I have to say, the Facebook group and the people who run it, thank you so much, because as I talk to people all around the world, they tell me that the Facebook group has saved their life because they see how people can live a long time, and that's not necessarily the understanding in a lot of countries. When that was posted in the Facebook group, members of our medical committee read the paper and then shared it with the Judith Tam ALK initiative at the University of Michigan. The ALK Positive committee then approached Astellas saying, hey, would you support a trial at the University of Michigan? Astellas, the manufacturer of gilteritinib. Then our Angel then submitted a grant application to ALK Positive, which our medical committee and organization decided to fund. So everything came together. ALK Positive was providing the funding. University of Michigan is providing the expertise in the clinical trial, and Astellas agreed to give the drug. So when those 3 things happened, and that included a $500,000 commitment from ALK Positive for the trial, now we could start the trial. Then the University of Michigan started, and Angel will tell us more about it. She showed in her patients that actually gilteritinib had activity in some patients, not all patients, with very little toxicity, which is what was expected because these ALK patients are very different from leukemia patients. And then we started then reaching out to Astellas on a regular basis. And I'll tell you, they told me no over and over again. But as the data mounted and the interest in our organization grew, we, the ALK Positive Medical Committee, kept going back. And fortunately, within the company, their ideas changed. In the meantime, the trial at Michigan wasn't enrolling very fast, in part because of the Nuvalent phase 2 that was open, and 2, because it was only in one site. So the Nuvalent phase 2 closed. And so now the need for a second line therapy became even greater. And so we, ALK Positive, pledged $400,000 to now expand the University of Michigan trial, while Angel was seeking NIH funding. And thanks to the Trump administration changes this year, there is no NIH funding. So if ALK Positive doesn't put up the money, the trial doesn't expand. Then Astellas called me one day and said, hey, we want to start a company-sponsored trial in 4 countries. And that was a day of celebration. So it really wanted to point out that it's becoming more and more obvious at conferences now, when doctors are presenting their scientific data, that they can't do it without patients. And I think if you look over here, the universities are a critical hub because they're doing the research and the testing in patients. But without patients, the universities can't do it. And the pharma biotech are critical because if they don't have the innovation in the new drug development, then the universities have nothing to test. And we patients have no way to move ahead and have new opportunities for therapies. So I think at ESMO, last week I was at the European Society of Medical Oncology, and one of the big keynotes in a room that held 9,000 oncologists and scientists. One of the presenters said, you have to include patients in everything you do, in your research, and in your testing, and in your treatment decisions. And I'm really enjoying it because it's becoming more and more a central fact and not just a nice thing to do. So in summary on this slide, I want to say that clinical advocacy, and ALK Positive is a beautiful example of that, is a team activity. And our work does increase treatment opportunities. And now you can see not only is it increasing opportunities in the US, but also in Spain and France and Japan, the 4 countries where Astellas is opening their trial. And as Mark presented at the ALKtALK a few weeks ago, we have multiple other trials that are going to be opening in the coming year that are going to dramatically increase the opportunities and the choices our patients have. And also, as I get ready to turn this over to Angel Chin, I want to say she's been a fantastic partner, as the whole University of Michigan team has been, and we're very much grateful for their partnership. And I also want to say a special thank you to Astellas, because without their willingness to provide the drug for these clinical trials, we couldn't do any of this. So this little triangular diagram here that ChatGPT so beautifully made for me, we wouldn't be able to have any of this. So our partnership is 3-way, and it's been really, and this is such a beautiful example of how that works. So the next 2 slides are details about the 2 Astellas trials. So one is the trial that was initially started at Michigan that ALK Positive is funding. We call that the University of Michigan Gilteritinib trial. And then the second one is the one that Astellas is now opening. And they're not identical, they're different. Angel Chin is the lead investigator on both, so there's no one better to tell us about the similarities and the differences than Angel. So Angel, the floor is yours.
Wonderful. Thank you so much, Ken, and thank you, Summer and Mark, and the rest of ALK Positive for having me back. I would like to have a jacket, to be honest. So please do invite me back for the 5th, just so I can get a jacket. But really, as Ken said, none of this would be here without all of you, without the ALK Positive team, without ALK Positive patients. And absolutely, I think it's kind of ridiculous. We even have to say we have to include patients, because at the end of the day, this is what we're doing all of this for, is for the patients. So this is our University of Michigan Gilteritinib study that we opened about 1.5 years ago. And through the support of ALK Positive, we are hoping to expand this into 2 other sites. So Cedars-Sinai, which is in Los Angeles, California, and then Georgetown University, which is in Washington, D.C. So hoping to aim for the coast, recognizing that not everyone likes to come spend winter with me in Ann Arbor, which I don't blame them. So with gilteritinib, because truly when we had designed the study, had really never been tested in patients with solid tumors. As Ken mentioned, it was really for patients with leukemia. We really didn't have a way to understand how patients with solid tumors, especially ALK positive non-small cell lung cancer, would do with gilteritinib. But we also did not want to do a traditional, what we call a dose escalation study. So most clinical trials for drugs that are in a new setting, they actually increase the dose little by little because of safety concerns. The good thing about gilteritinib is that we already knew it was safe in humans. There was an FDA-approved dose, and so we felt very strongly that we did not want to do another dose escalation. We instead choose to design it as a dose de-escalation, meaning we are going to start patients at the FDA-approved dose, and then if patients develop some toxicities, we would decrease the dose. And the rationale behind that is we didn't want to expose patients to non-therapeutic dosing. And as with any kind of not first in human, but first in this tumor study, our primary objective or the primary purpose of the study is to really understand the safety and tolerability. And for our study, the main criteria is that patients must have progressed on lorlatinib, and it does not matter any other number of therapies. It could be just lorlatinib alone, or lorlatinib, all the TKIs, chemotherapy, prior clinical trials with vaccines, immunotherapy, you name it. We're not excluding patients based on any of that. The other key criteria is that we are asking the patients to have something called measurable disease. That is just a kind of a technical term, meaning that on a CT scan or another type of imaging that we're able to measure how big the tumor is, and that we can measure it serially over time to hopefully see that gilteritinib is making it smaller. We are allowing patients to have brain metastases, which is really, really important. I think Mark shared that in the poll. The progression in the brain is unfortunately something we all have to be aware of. And we recognize it's a huge unmet need in our ALK community. And so as long as these brain metastases, patients are not symptomatic or needing any urgent therapy, we are allowing patients to get on the gilteritinib study. We're hoping to get 30 patients, and that is just kind of enough to kind of get us a safety signal as well as an efficacy signal. And glad to see that Astellas has taken up the call and also enroll additional patients as well. The cohorts there, I realize time and again as people review my study confuses a lot of people. So the cohorts don't mean anything. They just kind of list a possibility of different treatments patients have had. And the reason we kind of want to differentiate this is really the idea that someone who may have been exposed to many lines of therapy, like 6 or 7 treatments, may have a harder time tolerating a drug, for example, than someone who's only progressed on one. And so that is the cohorts are only there to help us understand dosing and working with our statistician. So that is, in short, our Michigan gilteritinib study. So if you want to go to the next slide, Ken. So this is the Astellas gilteritinib study. Right now, it's open at 2 centers already in the United States. Hackensack University, I think, is that in New Jersey, if I'm not mistaken?
Yeah, beautiful Garden State, yeah.
And then Virginia Cancer Specialist with Dr. Spira. And we are hoping to open it as well. And like Ken mentioned, it's going to be kind of across the United States in various sites, and then Spain, France, and Japan. They have a very similar study design to us because they also are pretty inclusive of patients. A key difference here is that they're actually allowing a population of patients who've only progressed on alectinib. So for patients, so unlike ours, where patients must have progressed on lorlatinib. Here, if you only progress on alectinib, you could potentially be eligible for the Astellas Gilteritinib study. And then the other big difference between our two studies is that Astellas study actually allows for even further dose up, because again, we mentioned we truly don't know what is the optimal dose of gilteritinib for ALK positive patients, is because it's been mostly tested in leukemia. And so in the Astellas study, if a patient has been doing well on the 120 milligrams, which is what we're all starting with, then they actually have an opportunity to escalate that dose to 240 milligrams, so double. And they will continue to assess patients, of course, in terms of how they're feeling, any side effects and things like that. So that'd be really exciting to see. Maybe a higher dose will be more efficacious, or maybe a higher dose would be a little bit more toxic. I think we'll have to see. Those are the two big differences, but we're just really excited that both studies with the same compound are now going to be available not only throughout the United States, but globally. And we're just really excited to see where this goes next.
So
That's all I have.
that's great. Let me add one thing to that, and that is that this dose escalation from 120 to 240, we believe it will be a safe transition, because in the leukemia population, they went to much, much higher doses.
Yes.
But because of the bone marrow compromise of leukemia patients, it's only 120. And so you're thinking, I think we're both thinking, right, Angel, that 240 shouldn't be a problem. Can you say something about the side effects you've seen in outpatients so far?
Yeah, so thank you for reminding me. We've been really impressed with our patients. We've had 8 patients dosed with gilteritinib, all at 120. We've not had to have any patients decrease their dose. We've not had any patients had any dose interruptions. I know Ken, on the slide, he listed things like joint pains, myalgia, some fatigue, liver function issues. We actually really haven't seen too much of that, except for maybe a very mild fatigue that patients said didn't really bother them in terms of preventing them from doing their day-to-day. So we've been really impressed, actually, with the tolerability of the 120.
So Summer, I think now we're at a point where you are now the boss.
And I was the boss all along. No, I'm just joking.
I was gonna say, I think she's always the boss, right?
Yeah, well, I like to try to not and reinforce that as much as possible.
Right. Don't encourage me. Don't encourage me. Okay, wait a second. I have a question. We have a lot of great questions coming in the chat for sure that you need to answer. And Ken, those slides were great and so helpful. Thank you so much. Okay, my question is, so somebody comes to you experiencing progression. How do you decide which trial they go on?
That's a really great question, Summer. I think that's a phenomenal question. So this is something that people ask me all the time in clinic, and I think there's a couple of things I look for.
Yeah.
So one, I look for the type of progression. So honestly, if a patient's progression is at a single site, I'm actually a firm believer in just localized therapy. So if possible, radiation, sometimes even surgery, and then continuing on their current treatment, because we truly want to make every treatment last as long as possible.
For sure.
The next important step is, if someone's had progression, have they had comprehensive imaging? And that includes, CT, chest, abdomen, pelvis, or a PET scan, and then an MRI of the brain, because if we see one area that's progressing, we want to make sure there's really nothing else hiding from us. The next question I have you had a biopsy, whether that is tissue or liquid? Because now my brain switches into, well, what kind of clues is your cancer giving me in terms of what might be driving the resistance? And we know from a lot of studies have been done, as patients have had different exposures to different TKIs and other treatments, their patterns of resistance are quite different. And so what might be for one person who progresses on alectinib, they'll likely look a lot different than someone that's progressed on alectinib and lorlatinib and so on.
I love
But
these steps. Yeah.
yeah, yeah. So
I
this
love-
is you're literally listening to like my brain talking to myself when I'm in the clinic with a patient.
And we can't say that enough. Again, have you had a biopsy yet?
Yeah,
Liquid and tissue. Yeah.
exactly. Tissue is ideal because
Mhm.
not only can we, you know, liquid might not capture everything, but tissue could also allow us to do additional staining from some of these additional drugs that have just been recently approved that Dr. Lin had mentioned at the summit this
Yeah.
past summer. So something called MET IHC and HER2 IHC that can only be obtained on tissue. But then at the end of the day, I look at what mechanisms can I detect. So if you still have, if the ALK mutation is still retained, I would favor of course, keeping a TKI as part of the treatment. Now, if we start seeing compound mutations, then we have to think about, based on the data that we're given, are any of the TKIs that we have available, including the neladalkib EAP, are any of those going to hit those mutations? If we're starting to see some other pathways creep up, you know, there are patients that, for example, have another mutation that arise that we actually already have a targeted drug for. Can I, you know, somehow go a little rogue and combine those safely? That's a question I ask myself. If I start seeing other pathways that are not as obvious, I actually think about this is the time to offer them gilteritinib because we know that gilteritinib can target many pathways. And then for patients who truly, the mutation profile is doesn't really reveal anything useful, that's actually when I might consider chemotherapy. Because we know that anywhere between 30 to 50% of patients don't have a mutational resistance mechanism that we can really characterize. And in those patients, I'd really worry about trusting just a TKI. I would think that maybe chemotherapy has a role. So there you go. That's what I do in clinic every day.
I love it. A little sneak peek, everybody, into Dr. Chin's mind. I love it. Okay, so then people are progressing or, you know, whichever, they've done these steps. They see that gilteritinib could be the choice for them. Should they go by location, what's nearest for them, or, you know, which of the criteria they might meet better?
Yeah, so we definitely, this is why it's so important for the studies to be open in many different places
Yeah.
across this country. Because really, you should go to wherever works for you to be able to get on a gilteritinib study if that's what you decide is right for you. Does not matter if it's the Michigan study versus the Astellas study. Just
That's
what makes
what I
sense
was
to you.
wondering also. Great. And
Mhm.
the Estella study too will be in other countries as well, which will be great.
Correct.
So that is super exciting. Okay, this was also helpful. Mark, how about, do you have any questions you want to throw out before we
No, I
look at?
think we should just start hitting the chat questions. Maybe Ken, if you want to, you can read through them and kind of go over which ones you guys want to talk about.
Yeah, actually, I want to make a comment, then I'll go, Angel can just pick. She can pick the ones that, if you
Oh
don't
my.
mind. What I wanted to point out, Angel just said something, she said a lot of really important things, but one thing I think we all need to remember is progression is not one thing. We say, oh, are you progressing? Are you not progressing? Well, where you progress, how fast you're progressing, what you've been, there's a lot more to I'm progressing than just one thing. And I think that sometimes in the way we talk to one another, we just kind of lump it all together. But as Angel just pointed out, it breaks out into a lot of different things. And of course, depending on that scenario, you may or may not be eligible for certain clinical trials. And right, and different treatments would make more sense than others. And if you go to for a second opinion, you know, that may also, they'll also be taking into account where, how fast, prior treatments. It's very complicated. And that's one of the reasons why we like the second opinion idea, is the collective wisdom of oncologists for progression is probably to your advantage. So sorry, Angel, I didn't mean to make you work extra hard, but did you find any there?
Every question is a good question. That's what I always say, Ken. So I'm
Yeah, I'll go through.
um
I'll go through and yell them out to you. Or do you see some?
you can yell them out. I'll let you be the boss, Summer.
Oh, thank you. Thank you. Ken's cheering or crying. I'm not sure.
A little bit of both.
Right. But again, and you both made such a great point. And I think looking back 5 years ago when I was diagnosed too, when you see these TKIs and you think it's a linear progression, but it's so far from that, which again was why I interrupted and said, yes, the biopsy. That's so huge. You can't really, if you're able to get a biopsy, you really need that because you don't know, what's changed or what's driving that cancer. So, okay. Okay, how about Gilteritinib and LMD? Have you had any patients with LMD or what do you anticipate? What can you say about that?
So I think that's a really great question. And I will be very honest. When we are testing new drug combinations, I really almost hesitate um, with LMD just because we know that it can be so aggressive that I'm always afraid that the treatment that we have is not going to be effective. I don't know if that's just kind of pessimistic of me. So actually on both the Gilteritinib studies, LMD is not included. However, with that said, I think one of the main reasons that the Astellas study is allowing a dose escalations, I think they do want to get a better sense of the um, get better sense of what would be an intracranial penetrance, because both studies actually do allow asymptomatic brain metastases. So I think we're getting there.
Okay.
LMD is such a very specific instance that requires such, I think, urgency to treat that I do think from a clinical trial perspective, that's why we've shied away from it.
But it could be something in the future, especially with
Yes.
dose
So
escalation.
Probably should mention what LND is, because hopefully most people
Yes, sorry.
don't know, right?
Yes.
We hope.
Yes, sorry. LMD is leptomeningeal disease. So the way I describe it to my patients, and please pardon me if this sounds like a silly analogies, I like to just say that your brain and your spinal cord, your central nervous system, is actually surrounded by like this thin layer of saran wrap. That's your leptomeninges, and in that saran wrap floats your cerebrospinal fluid. So your brain and your spine are like bathed in this lovely fluid that's enclosed by saran wrap. LMD occurs when the cancer actually is able to kind of invade that lining, the saran wrap. So you can see little studding all along the wrapping of the central nervous system. And as you can imagine, that can be particularly tricky to treat because unlike, let's say, a tumor in the lung where you could potentially aim, a surgeon's knife or radiation, it's really hard to go picking off little spots on a piece of saran wrap.
Great. Good. Not great, but good explanation. Thank you. And Ken, thanks for grabbing that for us. And we do hope to, in the new year, have an LMD and brain metastasis talk too. Just again, so we never know where progression or how is going to hit us. So just again, to educate yourself on that and provide support for those with brain metastasis and LMD. Okay. Would stereotactic radiation surgery to the brain be allowed during this trial?
So for the Michigan Gilteritinib study, yes. We designed that intentionally because we didn't know what the response in the brain would be, and we did not want patients who only have progression in the brain but maybe deriving benefit elsewhere to come off study. And actually, we had one patient do that, and actually he did great. He came off the Gilteritinib, got his radiation, got right back on without any issues.
Great.
The Astellas study does not allow that.
Okay.
They're a little bit more traditional.
Okay. And how about, so you have progression, some kind, and do you need a biopsy? I think I read this in the criteria, but do you need a biopsy or just a CT or MRI?
So for both studies, we say if we potentially any way if a biopsy of a tissue is safe and possible, we would 100% recommend that, and that's what I recommend in the clinical setting. However, we recognize that biopsies of a site of progression isn't always the easiest to obtain. And so for the Michigan study, then we would collect liquid biopsy and then your scans. The ALKtALK studies language stipulates that in those cases, will have to be a conversation between your oncologist and the ALKtALK, what they call the medical monitor, kind of like the person working on the ALKtALK side to oversee the study, and have a conversation as to whether or not they would allow enrollment without a biopsy.
Okay, thank you. And how about pneumonitis? I can't remember if that was one of the adverse events. Is there?
So, not that we saw. And so I think, with any TKI, especially in patients with lung cancer, we always worry about pneumonitis. But at least based on what we can see from the Gilteritinib experience in leukemia patients, pneumonitis really has not been an issue, nor has it been the patients who we've treated so far with Gilteritinib.
That is great because that is a scary one. Can you quick tell us pneumonitis? Give us a definition.
Yes. Pneumonitis just means inflammation of your lungs related to your treatment, and that could be a TKI. That can happen with immunotherapy, can happen with any anti-cancer treatment.
And it's usually like scar tissue, right? It's not really reversible, I think.
Yeah, so the scary thing about pneumonitis is unlike some of these other side effects where if you have a side effect, we hold the drug, sometimes have to give you supportive medications, you can kind of go back to normal, if you will. Pneumonitis, your lungs, they're not as they don't regenerate, I guess, in a way. They're not as resilient as we like them to be.
Mhm.
And so once inflammation damage occurs, sometimes patients are chronically have fibrosed, scarred lungs and need like oxygen.
Okay. Thank you. Soon you'll see, like on our social channels, little clips of all your definitions. I'm teasing, but thank you. This is so helpful. Okay. If you are currently being treated for a second cancer, for example, bladder cancer, would you be eligible for this trial? Great question.
That's a really great question. So
Mhm.
I actually modified the Gilteritinib study based on a patient, specifically in this setting, because we recognize that unfortunately some patients can have more than one cancer if they had cancers before. So for our Michigan Gilteritinib study, it specifically says if you have a second cancer, but that cancer is not the one of concern, that we expect you to do well with the other cancer, and that there's no concern, even if you're in treatment with the other cancer, of its interaction with Gilteritinib, that you be allowed on the Gilteritinib study. The ALKtALK study actually doesn't say one way or the other, so maybe we'll just let it slide.
That's great. Okay. If one progresses on lorlatinib and has the G1202R mutation, would you recommend that they go on Gilteritinib or ALKtALK expanded access program?
Ooh, great question.
Mhm.
Even though I love the Gilteritinib study, obviously, I have a bias there. I do think the data with neladalkib and G1202R is pretty impressive based on what we've seen so far from the ALKOVE study. So I actually would say that if they have an opportunity, I would probably go on neladalkib next. And then, God forbid, if they progress again, Gilteritinib is still there for them.
Okay, yeah, there is a part 2 to this question.
Okay.
What if? Maybe there's many people that this happens to. I don't know. Their ctDNA tissue shows I1171N compound mutation is preemptive trial enrollment reasonable.
Oh, I see. So my interpretation of that question is that this patient is having ctDNA showing this, but I'm going to say maybe not scans showing progression. I think this is the tricky thing about ctDNA. We don't really know what it means if we find something in ctDNA, but we don't see true evidence of progression on a scan. Does it mean it's going to progress? Does it mean it's going to progress soon versus much later? We don't know. So this is why for really any clinical trial, the demonstration of progression is on CT and not just on a ctDNA.
That makes so much sense. Again, such a great tool to have,
Mhm.
ctDNA too, but right, what are you chasing? Okay.
Right.
Let's see here. Can a patient be on another TKI after? This is to clarify a cohort that includes alectinib. Can a patient be on another TKI after alectinib progression and still be considered?
Oh, yes. So you, as long as, so for the Astellas Gilteritinib study, you can progress on alectinib, and that's your only criteria, alectinib, and then any other number of TKIs, whether or not
Okay.
it's alectinib, lorlatinib, and so on and so forth. So, and then with the Michigan clinical trial, it must have been lorlatinib. So lorlatinib could have been your first, lorlatinib could have been your second, and then, or your,
As
you know,
long as it's
doesn't,
lorlatinib. Right.
exactly.
Okay. Now, are there any secondary mutations if a biopsy is done and are there any secondary mutations that would preclude inclusion into the Astellas study?
Nope.
Great,
No, we want to include them all.
great. Again, more options. So we really appreciate that. Okay, let's see here. No treatment. Okay. Well, definitely, Dr. Chin, you're taking patients, right? For somebody in here saying they would like to be a patient. Yes,
Yes.
she's a fabulous second opinion. We would all definitely recommend her. Okay, great question. Please define LMD. I'm gonna have to come back to this other one because I can't read that much. When are preliminary results expected from these two trials? Great question. I love that.
That's a great question. So I think that depends on how fast we can accrue patients, and then how long these patients have been followed up, right? Because I think if you had like one patient that's done well, that's great, but then it's a little bit, I think, unfair to just show the results of like, oh, look, the one person that did great, but maybe the next 5 or 10 won't do as well. Similarly, if the first 3 patients don't do well, you don't want to show that and say, well, look, nobody does well, the dead drug, right? That's why it's so hard with small numbers. So I guess the answer to that is I don't know. I am hopeful that as we ramp up with our own Michigan Gilteritinib study into these other sites, that by next year I'll have some enough data where I would feel comfortable presenting it in an unbiased way.
And Ken could say too, we've heard from like a few random sources about patients doing well. So we're all kind of eager to see a collective.
There was actually just a oh God, I think a case report that got published of a patient doing well in Gilteritinib who is ALK positive. And it's one patient, but it's already out there. So
because it only takes one, right?
Just takes one.
We need to start somewhere, so that's great.
Absolutely.
Let's see here. Is radiation scatter all over your brain normal after radiation?
Radiation scatter. I think it depends on what type of radiation. So most often now, the radiation oncologists like to employ something called stereotactic radiosurgery or gamma knife surgery. There's a couple of different terms, meaning they really try to aim the radiation specifically to the area of interest and prevent side scatter, so affecting the normal brain. So there are patients that with more extensive disease in the brain, though, the radiation oncologist actually still recommends something called whole brain radiation, but that's in a very, very special case.
Okay, thank you. Okay, this is another great one. How about any thoughts on combining gilteritinib to shut down multiple pathways?
I think Ken actually asked me this when I was first designing the study. So he's like, hey, don't just combine it with lorlatinib. I I am hopeful that with the Gilteritinib, both Gilteritinib studies, that we will have enough preliminary data to feel comfortable about its safety profile. And once we have that comfort, I think that's where the space will be truly open for us to try to combine it with other TKIs. From a safety perspective, we'd hate to put Gilteritinib together with another TKI, not knowing the safety of it first, because then again, we just do not want to incur, strong toxicities.
Right. So hopefully eventually we'll get there, but how great to see, yeah, if it works by itself first. Okay, and I almost followed with Ken's lead and then didn't. And here's the question. So Meg, great question. What is ctDNA? Can you explain that? I'll need to edit this video and chop it all up to slide this.
So ctDNA stands for circulating tumor DNA. It's the idea that cancer cells, as they break off or as they die, they spill their contents into your bloodstream. So it's not just whole cells, but there's also chunks of their DNA. And so what technology has now enabled us to do is we can just draw, about 10 cc's of your blood. And then using very cool technology, they can actually go in and look for other chunks of just specifically DNA from cancer cells that we can find in your blood. And if there is, what that looks like. That really helps us to understand what is the cancer doing without necessarily having to do a tissue biopsy. But I would say both are complementary, that I don't think ctDNA replaces the tissue biopsy.
Yes. And a liquid biopsy, is that interchangeable?
Yeah, people call it liquid biopsy.
Right. So for me, my tumor burden wasn't enough or didn't shed enough. And many of you out there probably the same, because I've heard this, that then the ALK doesn't show up or there's not answers in ctDNA, which would be why you'd say you need a tissue biopsy.
Yeah.
Okay. All right, we have a couple more here. Let's say that phase 1 goes well and Gilteritinib is approved for phase 2. Do you have an FDA approval timeline?
Oh.
Or we're not there yet?
The FDA, they sometimes surprise you with what they will approve something based on. I think it depends on the strength of our data. It would also be nice if our government, was working right now.
There was a little caveat at the end of
there
that
might be a
question.
bit of a backlog.
But this drug's already been approved for leukemia, so it's could go a lot faster. How many slots do you have for at Michigan, and how many slots for the other East Coast and West Coast do you think they might have?
We've basically 30. We had, I think, 8 for both of the coasts. So that's 16, and then 14 for Michigan. That makes up 30. And then Astellas, they just want to enroll 40 patients across the 4 countries.
Okay, and then can you give us an idea? I don't know if you can or can't. The 8 patients that enrolled, uh, were they successful? What were their profile? Any idea of from a clinician standpoint, why did they enroll in your drug? Give us an idea.
Yeah, so we've actually had quite the spectrum of patients who've enrolled in our study. We've had patients who've progressed even on neladalkib, so the NVL compound. We've had patients who've progressed only on lorlatinib and then chemotherapy. So I think our range in terms of prior lines of therapy range from 2 to 8, so a very large spectrum. Right. We've had a few patients do really well. I will say surprisingly well even. One patient, like I mentioned, who actually had the brain metastasis, initially the brain metastasis did shrink. And then when it came back, it grew again. We actually did radiation. They were able to do well. And then unfortunately, we've had a few patients not do well. They took the drug, but the cancer had already been accelerating at a pretty quick pace that the Gilteritinib itself wasn't enough to stop it.
And I just want to say, from being in 2 clinical trials, a lot of the patients who enter into the clinical trials are heavily treated already and are not in decent shape, in my opinion. But measurable disease, is there 1 centimeter? What is measurable disease for the trials?
Yeah, so there's something that all clinical trials, when they say the words measurable disease, they are using something called the RECIST criteria, RECIST. You can Google that. It's just a standard language. So it requires a certain non-lymph node lesion to be at least 10 millimeters unequivocally in size or bigger in a site that was not recently radiated. For a lymph node to be considered target disease or measurable disease, it has to be 15 millimeters in its short axis. Things like bone are actually not considered measurable disease unless you have a soft tissue component, because bones, it just looks like this kind of what they call moth-eaten appearance, and it's really hard to measure like the jagged edges. Things like pleural fluid, that's not considered measurable disease because obviously you can drain the fluid and then you really wouldn't be able to address that.
And then one other thing that I'm just curious as a clinician also, it's a good thing to have all the TKIs that we developed over the years, but how do you decide on where to place your patients? And you kind of went into a little bit at the very beginning, but how do you think that this drug would compare to other drugs? Is this considered to be a fourth line treatment, a third line drug? Where does it fit in?
Yeah, I think this is probably actually one of the reasons Astellas wanted to include patients who've only progressed on alectinib, because they want to kind of get an understanding of where this drug might fit. Does it fit in the second line, third line? Does it fit? Can we ever do a frontline study, right? We really don't know. And I think this is why, for me, it truly is an individual discussion as to whether or not I think gilteritinib is right for someone. I think if someone were truly kind of out of options, we always want to have an option to offer. So gilteritinib is there. But again, if they're kind of earlier on and we're seeing a clear resistance here that we think might be better targeted with something that is known, for example, neladalkib, then that might be the better option.
And explain to the audience the on-target mutations, off-target, which are more pathways. Does this drug explain the TKIs in simple fashion, how they do work, and if you do have a pathway that's a MET or another pathway, does this TKI show any of that?
Yeah, so when we talk about resistance mechanisms, it's really two main ones. So one is something called on target, meaning you still have your abnormal ALK protein, but that the mutation has changed in a way that might make your current TKI not able to bind to the pocket to stop the functioning of that protein. And this can get more complicated if you have multiple mutations, or something that we call compound mutations, where now several ALK mutations have existed. So your binding pocket is like really weird. And this is where some of your fourth generation ALK TKIs like neladalkib was designed for that purpose. When you talk about off-target resistance, we're talking about two things. So the first thing is these other pathways. So now your cancer cells like, well, you know what? You try to keep hitting me with ALK. I'm going to something else besides ALK is now going to become the driver that persists. So I'm going to go with another signaling pathway. And this is where we've been trying to do things like, if we see a MET, can we target it with a MET drug? Like, for example, Dr. Patil's study with amivantamab. There's a lot of case reports of using crizotinib, right? Crizotinib, the original ALK TKI, was actually a MET inhibitor too. Or some of these other pathways we don't really have as many great targeted therapies for. And that's where something like gilteritinib, which actually targets multiple pathways beyond just ALK, is really of interest. And then there's the final mechanism that's off target. It's actually when when the ALK cancer becomes a different histology entirely. Most ALK is adenocarcinoma, but sometimes it can transition and become a small cell lung cancer. And this is why, again, tissue is so important, because this is not something we can detect in the liquid biopsy. This is only something we can detect with a piece of tissue. So that's what we really talk about.
So I just want to follow up with that. So are you saying that this TKI drug is going to be better for other pathways off target versus MVL or any of the other drugs?
So that is a hypothesis that we're trying to test, right? Because NVL, after all, is designed to be a very effective ALK inhibitor, but its primary effect is ALK. we don't really know or don't really think that it targets too much beyond ALK. So again, if you have an ALK resistance mutation, NALDALKib seems really great. But as you start to have these different mutations arise that are no longer in the ALK pathway, this is where the hypothesis comes in that you might actually do better with something like gilteritinib, which targets multiple pathways.
That's great news. Ken, I don't know if you have anything else to add or final thoughts before we.
Only we're so grateful for Angel for the fantastic presentation. Thank you, Angel.
Thank you. It's always my pleasure.
Yes, we'll for sure have to have you back on for the jacket. Well, I don't know that if Summit will count for that, but no, thank you so much for spending your evening with us. Also, and this Gilteritinib, both trials, but at least how it got started with the University of Michigan is again such a great example as we come up on LCAM, how research is powered by patients. You know, more research equals more life. Without research, without clinical trials, there would not be treatments. And again, you help all of that come to fruition. Our patient community, working hand in hand with these researchers and clinicians. So thank you so much. Katie is going to throw in the chat our links so that you can spread awareness during this LCAM season. More research equals more time. And we want to know from all of you what more time means to you. For me, it was more time, means more football games with my family. So if you can want to make a card to share on social media, to keep for yourself, whatever you'd like to do. If you're not out there in the world, it can be a backwards shot. Someone did a cartwheel last year. It was fun. So, and also if you would like to use those cards to get started with a fundraising campaign or platform, we can help you do that as well. We have a $2 million goal to fund more projects and more life-saving research. So we really want to get things moving in that direction. So check out the chat for those links, please. Also, remember, there actually will be an updated November calendar. I believe Care Partner check-in is changing, so be on the lookout for that. There is a Death Cafe tomorrow. Dana, do you want to say anything about that?
Hi. Yeah. So the Death Cafe topic is, would you have a like a living funeral or a celebration? People always make time to come to your funeral, but would you like to have something where people come and celebrate your life with you versus after you're gone?
I have to say, it's not as deathly as what the title might be. It goes into
Death
different
Cafe is-
directions. So,
It that
Dr. Chin, don't worry about it. You don't
several
have to
times.
show up.
Everybody wants to keep the name. But it's just topics that you might not really think about you don't want to talk about with you might not be able to talk with your family about. So we kind of, and then we go in small groups, so it's not a giant discussion. You talk with like 2 or 3 people only.
It's amazing. It's an amazing platform. It's a safe space to talk about those things. You know, when I get annoyed and say under my breath to somebody, well, don't show up at my funeral. You know, that's why it's a place that other people might relate to my snarky comments. Yeah. So check out the website if you would like to join that tomorrow. We will see you on November 9th with Dr. Kamich. Will be our next ALK Talk. So again, Dr. Chen, thank you for joining us and for all of your work in the clinic and in the lab, helping us to move forward. We so appreciate it. And if everyone would like to unmute and share your thanks, and then have a great night, and we'll see you in a couple weeks.
Thanks, Angel.
Thank you.
Thank you.
Thank you.
Thank you, good people.
We appreciate you.
Thank you.
Thank you.
Thank you.
Awesome.
So awesome.
Thank you, Angel.
Thank
Take
you
care,
so
everyone.
much. Take care, everyone.
Bye-bye.
Bye.
Bye-bye.